Hello and welcome everyone. Today we'll be discussing regarding the interaction of immune system, the endothelial system and the hemostasis system in a sepsis. The immune response, coagulation and endothelium, they work together in a regulated physiological host response to infection. A dysregulated host response occurs when the interaction between these systems becomes unsynchronized. This is the central concept for the definition of sepsis that we have been following since 2016. This dysregulated host response was common in critically ill syndromes like sepsis, ARDS, and pancreatitis. In sepsis, the dysregulated immune response involves disruption in the immune-driven resistance, disease tolerance, and the resolution mechanisms. Effector immune mechanisms reduce pathogen burden by detecting, neutralizing, killing, and expelling the microorganisms, largely driven by the inflammation via the innate immune system. Immune thrombosis refers to the immune response role in thrombin generation and microthrombus formation, aiding the pathogen recognition, containment, and its destruction. During sepsis, this response becomes dysregulated, causing intense activation of the leukocytes, platelets, and the endothelium, excessive coagulation leading to DIC, multi-organ dysfunction, and high mortality rates due to defective anticoagulation and fibrinolytic pathways. Targeted strategies to control the excessive immune activation, thrombin generation, and endothelial dysfunction may improve survival in affected individuals. So, what is the pathophysiological mechanisms of this interaction? Monocyte and neutrophil play a critical role in sepsis by activating inflammation through the receptors such as the toll-like receptor, Fc gamma receptor, G protein coupled receptor, protease activator receptors. Monocyte in sepsis release pro-inflammatory cytokines and activate the innate immune response, leading to neutrophil activation and the formation of NET. NETs are condensed DNA fibers containing site-related histones and enzymes like myeloperoxidase and neutrophil elastase. Now, microvesicles, that is MVs, are submicron vesicles released by the activated cells, that is endothelium and leukocytes, during sepsis. The MVs promote inflammatory signaling in the blood vessels and the heart by expressing tissue factor. MVs expose the phosphatidylserine, which induces procoagulant and anticoagulant complex systems in the cell surface. MVs can also exhibit fibrinolytic functions. So the NETs and the MVs co-localize, forming surfaces that enhance blood coagulation through the contact pathway, contributing to the procoagulant activity of the NETs. NETs have a strong affinity for platelet binding, thus promoting the clot formation. In sepsis, leukocytes contribute to the various forms of cell death by necrosis, necroptosis, pyroptosis, releasing cellular components that act as damage-associated molecular patterns, that is DAMPs. DAMPs include DNA, histones, and HMG1, are highly pro-inflammatory and procoagulant. The DAMPs enhance the pro-inflammation by binding to receptors for PAMPs. So now that we have seen the inflammation, let's see how the endothelial is responding to the sepsis. The endothelial response to inflammation is crucial for controlling the infection, but can also become harmful when it occurs systemically. Sepsis triggers a procoagulant, propermeable, pro-adhesive endothelial surface, leading to extremely harmful systemic effects. The systemic inflammation causes shedding, degradation of the endothelial glycocalyx, which is a protective gel-like layer over the endothelium. The glycocalyx is composed of proteoglycans, glycosaminoglycans, and polysaccharides, binding functional proteins like antithrombin. The inflammation easily disrupts the fragile glycocalyx, exposing the procoagulant endothelial surface to the inflammatory and the coagulation agents. This exposure leads to an increased expression of the tissue factor, von Willebrand factor, on the endothelial and the monocyte surfaces. The tissue factor triggers coagulation by generating excessive thrombin, which converts the fibrinogen into fibrin, forming an insoluble fibrin network. This coagulation process is enhanced by the bacterial polyphosphates, which also inhibit fibrinolysis. Thus, sepsis induces the release of pre-stored von Willebrand factor, resulting in an abundance of ultra-large von Willebrand factor multimers on the endothelial surface. These ultra-large multimers aggregate the platelets and impair the microvascular perfusion. The increased endothelial expression of the adhesion molecules, that is ICAM1 and VCAM1, promotes the leukocyte adhesion and the transmigration into healthy tissues, contributing to the organ's failure. A systematic review found that while the plasma glycocalyx component increase in sepsis, structural imaging does not consistently show a corresponding thinning in the endothelial glycocalyx. There is no clear evidence linking higher plasma glycocalyx fragment levels with increased capillary permeability. So now that we see how the inflammation and the endothelium have reacted to the sepsis, let's see how the hemostasis is getting affected. The hemostatic system plays a critical role in the initial immune response by trying to confine and neutralize the pathogen within these clots. Some pathogens can specifically target the coagulation pathways by enzymatic activity to dissolve the fibrin clots, by inhibition of the platelet aggregation. Excessive and dysregulated coagulation in sepsis leads to overproduction of the thrombin, contributing to the sepsis-induced coagulopathy. Fibrinolysis involves the conversion of fibrin-bound plasminogen to plasmin by tissue plasminogen activator and the urokinase, cleaving the fibrin and releasing the fibrin degradation products like D-dimer. Plasmin generation is regulated by plasminogen activator inhibitor 1 and thrombin activator fibrinolysis inhibitor TAFI. Sepsis-induced DIC is often linked to defective fibrinolysis due to the increase in PAI1 from the endothelial cells and the platelet. The TAFI activation, the plasminogen degradation by the neutrophil elastase from the nets, and the sepsis results in a reduced plasma concentration of natural anticoagulants, that is the protein C, protein S and antithrombin, leading to the ineffective counterregulation. Tissue factor pathway inhibitor limits the coagulation cascade by interacting with the coagulation factor 7, 10 and tissue factor. Purpura fulminans is a classical example of hemostasis dysfunction in sepsis associated with infections like meningococcal and pneumococcal infection, characterized by rapid DIC, epidermal necrosis, and inflammatory vasculitis. Platelets not only contribute to the coagulation but play a role in the innate immune system, promoting the neutrophil activation and recruitment of the leukocytes via the P-selectin. Platelets express TLR4 and activate the complement pathway as well. The complement system bridges the innate and the adaptive system and can be activated by pathogens as well as DAMPs. It plays a protective role against infection but can also contribute to the hyperinflammation that we see in sepsis, which may ultimately lead to multi-organ failure. Now, the anaphylatoxins, that is C3A and C5A, promote the platelet aggregation and the release of pro-inflammatory mediators. So now that we know how all the three systems are getting affected in sepsis, what are the clinical aspects of the disturbance in this? In 2001, the International Society of Thrombosis and Haemostasis released the diagnostic criteria of DIC, primarily helping us in diagnosing the advanced DIC. The criteria may result in delayed diagnosis, reduce the treatment efficacy. The SITH later developed what is called as the sepsis-induced coagulopathy, the SIC criteria, to detect the early phase of the DIC. Now, SIC includes a simplified organ failure assessment, platelet count and prothrombin time, which are easily calculated at the bedside. Studies show that the prevalence of SIC in sepsis is around 22 to 24%, and patients with SIC have significantly higher mortality rates. In the high-press study, the 90-day mortality rate of patients with SIC was 26.8%, nearly double that of patients without SIC. SIC is considered as an early warning sign of sepsis-associated injury. Several studies have shown that SIC score to be a reliable predictor of mortality. Chen et al. Found that SIC and DIC scores have equal ability to predict a 28-day mortality. Lee et al. Showed that SIC and SOFA scores had comparable accuracy in predicting 28-day mortality. Despite the known link between coagulation activation and organ dysfunction, microvascular thrombi formation is rare in septic form patients. In an autopsy study of 51 septic patients, only 3 had microvascular thrombi, suggesting that thrombosis may not really play a significant role in sepsis pathogenesis. The incidence of AKI in sepsis varies, with White et al. Reporting around 16% of septic patients meeting the AKI criteria. The AKI severity increases with DIC. About half of the patients with sepsis-associated DIC and shock required RRT, compared to only 21.3% without DIC. Helms et al. Showed that nearly 50% with sepsis-associated DIC required renal replacement therapy, which was more than the double with non-DIC. Now, a close association with DIC and AKI has been observed in multiple studies, and it is linked to poor outcomes as well. The kidney's unique vascular architecture, particularly its glomerular capillaries, make it vulnerable to microthrombus formation. However, histopathological studies show that sepsis-related AKI often present with normal or mild non-specific renal changes. That is, structurally we don't find much changes in the kidney. So now that we know what can be the clinical presentations, how do we assess this at the bedside? How do I know in my bedside that my patient's endothelial system, the hemostasis system and the immune system is dysfunctional? So first, let's try to assess the immune system. Clearly, we need to fall back on our biomarkers, but as of now, we don't have a single biomarker which reflects the overall immune response. Interleukin 6, TNF are variable, and we need better standardization of our cytokines, proper predictions. Cellular activity tests like flow cytometry, CD4, CD8 ratios, HLA-DR expression on antigen-presenting cell, and T-cell checkpoints provide more insight, but they do have their limitations. Persistent lymphopenia may indicate immune dysfunction, warranting further tests. Regarding endothelial integrity, maintaining the endothelial integrity is critical for the oxygen delivery. So we have side-stream dark field microscopy, which visualizes the glycocalyx disruption and may guide real-time therapies. Elevated biomarkers like proadrenomedullin levels suggest endothelial dysfunction and correlate with increased mortality risk. Other potential markers are angiopoietin 1, 2, TIE2 axis, but they are still early in phase of research. Hemostatic dysfunction, the DIC criteria, the SIC scores for early detection for us. SIC scores are simple bedside tools which can be done and found high-risk patients. Thrombocytopenia is a common thing and it is associated with worse outcomes. Point-of-care tests like TEG and ROTEM are used to assess coagulation abnormalities, but they do lack strong evidence for a role in detecting SIC. So what is the impact of standard sepsis intervention on the coagulation endothelium? That is the therapies that we give day in and day out. How do we affect our systems? First, the fluid therapy. Excessive fluid administration can cause glycocalyx shedding, leading to increased capillary leakage, tissue edema, and microcirculatory impairment. Angiopoietin 2 levels rise with fluid overload, contributing to the endothelial dysfunction and permeability. Fluid overload also dilutes the coagulation factors, exacerbating the SIC. Crystalloids are recommended for septic, as colloids have no benefit and may increase the coagulation abnormalities. Albumin may protect the endothelium due to its antioxidant and immunomodulatory properties, but hasn't shown mortality reduction in large trials. Coming next is the vasoactive therapy. The endothelial releases vasoactive factors like nitric oxide, which in excess contribute to the sepsis-induced vasoplegia, myocardial dysfunction, and bioenergetics failure. Norepinephrine is the first line that we use, followed by vasopressin. Angiotensin 2 shows promise as a non-catecholamine vasopressor, potentially enhancing immune response in sepsis. So, do we actually have any therapeutic targets as of now to correct this? The commonest one that we keep using is steroids, widely used in sepsis due to its anti-inflammatory effects, reduces the release of pro-inflammatory factors, reactive oxygen species, stabilizes the cell membrane. It may help in endothelial integrity by decreasing vascular permeability and enhancing the responsiveness to catecholamines. The effect of low-dose steroids have shown mixed results in various trials. A meta-analysis of 7,000 patients showed no significant difference in 90-day mortality, but the increase in vasopressor-free days. Adverse effects include superinfection, hyperglycemia, GI bleeds, but they were not significant. In patients with severe CAP, steroid therapy reduces the need of ventilation, but had uncertain impact on the mortality. Steroids are associated with high mortality in respiratory failure caused by influenza virus. Guidelines recommend steroid of 5 to 7 days for severe CAP though. For immune mediator function targeting, therapies targeting excessive cytokine production have shown to limit success in clinical trials. A trial targeting TLR4 signaling showed no improvement in mortality. Anakinra antagonist, no effect on stratified sepsis. Gangibotide, that is an inhibitor of TREM1, showed promising results in type 2B trial, but a phase 3 trial is in development. Regarding intravenous immunoglobulins, historically proposed an adjunctive therapy to sepsis, but till now we don't really have much supporting evidence for this. IgM-enriched IVIG shows potential for immune modulation and has shown promise in reducing mortality in pooled analysis, but results are inconsistent in higher quality studies. So in endothelium and hemostasis, do I have any therapeutic target? Regarding the endothelial system, albumin we say is a potential factor which can restore the glycocalyx. It is suggested for patients receiving large volume crystalloids, potential anti-inflammatory immunomodulatory effect. We have enibarcimab, a non-neutralizing monoclonal antibody targeting adrenomodulin, which may reduce sepsis-induced vasodilation and endothelial leakage. The phase 2A trial showed safety, tolerance, and potential reduction in SOFA scores. Imatinib, a tyrosine kinase inhibitor that has shown reduction in vascular leakage in case of idiopathic vascular leakage syndrome. Regarding hemostasis system, anticoagulants have been used. Early trials with heparin, activated protein C, antithrombin, antisurfactor inhibitors showed no mortality benefits. A more recent recombinant thrombomodulin trial showed no mortality reduction but a trend towards benefit in patients with baseline coagulopathy and no concomitant heparin thromboprophylaxis. A separate trial with thrombomodulin for DIC showed superior DIC resolution, that is 66% versus 50%, leading to approval in Japan for DIC management. The failure of anticoagulant trials may be linked to factors like timing, the dosage, the patient selection, with recommendations to shift endpoints to DIC resolution and organ function improvement rather than targeting everything to a 20-day mortality. Complement inhibitors. Various complement inhibitors are there which have shown promise in abnormal models with improvement in endothelial function, reduced coagulopathy, and better survival outcomes. Plasma exchange is another therapy which has been seen, but there are challenges with this. We need more research to establish these things. So the mechanism underlying sepsis, septic shock, multi-organ failure are still not completely understood. Bacterial proliferation and toxin production may directly damage the organs, disrupt the vital functions. Activation of the innate immune system can lead to dysregulation of humoral and cellular immunity, affecting both coagulation and endothelial function. The disturbed interaction between immune response, coagulation, and endothelial systems may explain how localized infections lead to systemic complications such as ARDS, altered sensorium, shock, AKI. Sepsis-induced immune endothelial hemostatic dysfunction are part of large systemic dysfunction that ultimately result in this organ failure. A deeper understanding of this mechanism with new diagnostics, tests, and therapeutic targets may help us in better managing sepsis in the future. So to summarize, this is the pathophysiology, the endothelial dysfunction because of the altered permeability, increased coagulation factor expression, leukocyte adhesion and transmigration, the immune system because of increased pro-inflammatory activity, decreased anti-inflammatory activity, the altered coagulation because of increased procoagulant and decreased anticoagulation action. All of these promote the dysfunction of the triad. So how do we measure this? We still are not very close. We need further research. There are various tools, as we have already discussed. Finally, leaving you with the studies and the interventions, the rationale of use, and the outcomes that we have seen. Thank you for your patience.